Association and the Systems Medical Director of Bon Secours Mercy Health in Greenville, South Carolina. Great to see you tonight, Dr. Felkel.
Glad to be here. Thank you.
You're welcome. And we have also with us Dr. Bernie Ranchero, who is a family medicine doctor who also received his master's in science as well as an MBA, and is the medical director of Leadwell Division Hospital Sisters Health System in Charleston, Illinois. Nice to see you, Dr. Ranchero.
Thank you.
I'm your moderator tonight. My name is Dr. Rachel Earls. If you have any questions during this webinar, please enter your questions in the Q&A function, and we will address them as best we can. The chat function is turned on, so off. So again, I just want to reiterate, please enter your questions in the Q&A. So to begin, how I want to start this webinar is I want to ask each panelist, when did you realize that GeneSight was critical to care for your patients? We can start with you, Dr. Felkel.
Sure, you can start with me because it wasn't me who got a patient well. It was me having another psychiatrist get my own patient well that really opened my eyes to GeneSight. This was about 10 years ago. I was co-located in a pediatric office as a child psychiatrist. Really believe in co-location and integration. And in walks a kid named Ethan, and he had really severe OCD and depression. And I did what any child psychiatrist knows how to do, and that's get him to exposure response therapy for his obsessive thoughts about being contaminated and his compulsions to hand wash. He was severe on his Children's E.L. Brown Obsessive Compulsive Scale, had a high PHQ. I'm sure many of you all are doing measurement-based care out there. Anyways, I started him on sertraline, Zoloft, got him all the way up to 200 milligrams with really no improvement. His parents hospitalized him. He was on homebound at that time. And at this specialty hospital, they started him on Abilify, and he had just gained 40 pounds on that and came back to me more depressed than ever. So I took him off the Abilify, Zoloft, and put him on Prozac, FDA approved for OCD in his age group. And he didn't get any better. In fact, he tried to jump out of a car because it activated him, I believe. So I reached for clomipramine, a TCA, and I just wasn't getting him better. And so his parents hospitalized him again. And during that hospitalization, a psychiatrist, a really smart one, did a GeneSight. And it showed that Ethan wasn't responding because he was short at the SLC6A4 gene, the serotonin reuptake protein gene. He was heterozygous at the sensitivity gene. So I think my medicines were making him way more sensitive. And he was a poor metabolizer at multiple pathways. So that Prozac, Zoloft, clomipramine dose were too high. And so that psychiatrist, not me, started him on Cymbalta, duloxetine, got him up to 30 milligrams twice a day. And he went into a full-fledged remission. Back to work as a 15-year-old at this time at Chick-fil-A, no OCD, full remission. And I was left feeling really guilty. And so, Rachel, that really is what opened my eyes to it. And I just started learning from there. So thank you.
That's an incredible story. Thank you for sharing. What about you, Dr. Thomas?
Great story, Dr. Felkel. I like that. Well, I don't have nearly as good a story as that, but I was at a conference probably around 2009 or 10, and somebody there mentioned it as a part of their presentation, and I was intrigued by the notion, made myself a little note, and so of course went down the rabbit hole of trying to figure out what is this that they're talking about. And it wasn't until a couple of years later, I think in 2012 is when I started using GeneSight. And a psychiatrist friend of mine, somebody had gone to call on her, and where she worked, she wasn't able to do that. But she gave him my name and number and said, I think she would probably be interested. And so they showed up at my office, and I've been doing it ever since.
Thank you. And Dr. Ranchero, what about your experience?
So my experience with GeneSight actually goes back several years. I heard a presentation that Dr. Felkel gave at Northwestern University in Chicago, and that's where I was introduced to GeneSight. Interestingly enough, about 10 years prior to that, he was my medical student when I was chief resident in Chicago. So that's how I know Carson and Dr. Felkel. And so what really prompted me to dive into GeneSight in the last few years was just the pragmatic aspect of it, especially with being a busy primary care provider. the level of anxiety and level of depression that we saw through COVID and through the pandemic just became elevated. And I needed another tool in my chest, and a good tool in my chest. And after thinking about what I had heard Dr. Falco mention about GeneSight and teach about GeneSight, and then having a rep come in, it really made a difference in my practice in how I approach, especially when it just comes to the bread and butter, anxiety and depression. And again, it's a great tool to help me and also the patients have onus in their own healthcare.
Thank you. 3 different paths, but they all led you to GeneSight, which is great.
Rachel, I have to say that even though Bernie taught me everything I need to know about family medicine, he also birthed my oldest child. So he did a great job with that.
Thank
So
you.
we go far back.
We set up the webinar. This is news to me.
No, we didn't. No.
A very small world. I love that. Well, it sounds like what I'm hearing is there are a lot of reasons that you can hear about GeneSight, but for you, Dr. Thomas, as well as you, Dr. Ranchero, it was hearing it from a peer, hearing about it as a tool. Dr. Falco, similarly, when a psychiatrist that you were working with told you about it. So we're so thankful that everyone is here tonight to learn a little bit more about it. I am going to share my screen. So everyone who's attending will be able to see what a sample report looks like. We also have in the Q&A feature, we have a link to a sample report that you can look at as well. So please follow along, try to engage, and I will have this on my screen for the duration of this webinar. So you will be able to see what we are talking through. Thumbs up, everyone can see the report?
Yes.
Yes.
Wonderful. Okay, so for the rest of this webinar, what we're trying to do is we're going to break down the report into different sections. There are technically 3 different sections of the GeneSight report. They don't always get talked about, and we're going to talk about why they're there and what information you can learn from them. So section 1 is shown here. It's the section where you see the green, yellow, and red. It's called the interpretive portion of the report. And this is where you will see medications placed into different colored bins and assigned clinical considerations. If you keep scrolling, we also see a section that lists the patient's genes that we test for and their results, which is called a phenotype. We'll talk about more of that later. And lastly, we have something called a gene-drug interaction chart, which tells you information on which genes metabolize each medication on our report. So we're going to break this down one by one. The important part here is that you do not have to know all of this to use the GeneSight test. This is just information that is available to you. So we're going to start with the green, yellow, red section, or the interpretive portion of the report. And I'm going to start talking to Dr. Ranchero. So Dr. Ranchero, we know that you're a primary care provider, and so your perspective on using GeneSight is critical. We know it is used very frequently in primary care. So from a provider to provider, how would you explain the first section of the report? How would you explain this to a colleague?
Right. And I'm going to take a step back even and say, when I talk to a colleague about GeneSight, it's really, this is a tool, and it's allowing the clinician and the patient to make an educated decision versus just saying, okay, let's start you on Zoloft, let's start you on Sertraline, let's start you on Lexapro. And I'm guessing, and I'm taking some of the guesswork out of it and making an educated decision. And I'm also letting the patient know that I have an option here. I have a tool where I can do a genetic test on you to see which medications would be best for you. And I say, it's 2024. We should have this tool, and we should use this tool to better make a decision on what to use for the patient. In a busy primary care practice, we know that cardiovascular disease is still the #1 killer. We know we have to treat the diabetes. We know we have to treat the hypertension, the hyperlipidemia. We know we have to treat the chronic pain and everything that comes along with it. But we also know that if we don't have a patient whose depression or anxiety is under good control, how is that going to affect their health? And so letting that clinician know that if we don't have buy-in from the patient, we don't have that trust, we don't have that rapport, we don't have that relationship from the patient, then are we going to get better outcomes? The answer is, of course, is no. And so we need to have the tools. And this is one tool. I mean, I did several GeneSights today. And one of the things I'm telling the patients is, I'd like to do a test on you where I can individualize And based on your individual DNA and based on your genetics, we can both make an educated choice, that shared decision making, and letting the patient know that, okay, we could try, I could guess and start you on something, maybe something common, or we could wait a few weeks, 2, 3, 4 weeks, get a GeneSight back and make an educated decision together. And it'll be individualized towards you. And by the way, this DNA that we're going to collect doesn't go into some national database. It gets destroyed. And letting the patient know that this is theirs to keep. It's one and done. Any updates, any upgrades will be done in the future, and it individualizes it for them. And then it's getting that patient buy-in and saying, hey, look, this is you. And, letting them know that we can make a decision together. So I'm going to keep things simple, because when I first saw this, these 15 pages, it can be overwhelming. But as it says on top here, there's green, there's yellow, and there's red. The green uses directed. Now, am I oversimplifying it here? But perhaps for some new primary care clinicians out there, we need to keep things simple for the patient, keep things simple for the clinician, because we have so many other things that we need to do. But we know if we can take care of the patient's anxiety, will that help with the blood pressure? We know if we take care of that patient's depression, will that help with the cardiovascular disease? The answer is yes. And helping that patient, if the patient doesn't care about their own health, then we need to start there. I know there have been numerous studies out there that if we treat the patient's underlying psychosocial issues, behavioral issues, will their diabetes improve? Will their blood pressure improve? Will their cardiovascular disease improve? Will their pain improve? The answer is yes. Will their obesity improve? The answer is yes. So the green uses directed, the yellow, moderate gene drug interactions, the red, significant gene drug interactions. That just means that there are some clauses and qualifications. Doesn't mean you can't use something from the yellow. Doesn't mean you can't use something from the red. And if the patient is ready on something and it is efficacious, doesn't mean we switch them. But it also can mean, especially since we're in primary care, where oftentimes we're the gatekeepers to behavioral health care, we can make an educated decision before we start, instead of saying, let's see how you do in 6 weeks. Let's see how you do in 12 weeks. Oh, let's make some dosage changes. Oh, let's switch you over again. And now 6 months have passed. And how has that patient's quality of life been affected? So starting from scratch and saying, okay, like this sample we show here, you know what? Let's look at what we can start in the green. And then we also have to have the considerations of, okay, what's on the patient's formulary? What can the patient afford? Can the patient have access to? We have to think about all those things, because we might say, we want to start Trintellix on this patient. Well, we know that based on formulary, maybe they have to try and fail to unbranded SSRIs and an SNRI before I can put them on Trintellix. And so this helps us make a decision for the patient. So that is a big way I can use this tool. And also saying to the patient, look, say something, they want to be on bupropion because they also want, they want to be on a medication to help them lose weight. Well, serum levels may be too low, higher doses may be required. That helps me make the decision that, oh, wait a second. Okay, it's in red, but I still can use it. And I probably want to use it in someone who wants to lose some weight. I want to use it in someone who wants to stop smoking. I want to use it in those patients. So that's where I use this in a simple way, but also convincing the patient and letting them know, hey, look, green, yellow, red. Let's try to get something that we can use. It doesn't mean we can't use something from the red, but what is it? What are the clinical considerations that you see below in the numbers below?
Rachel, you threw a hard report at us, and I think it's also in the links. Everyone should click it. But if you're primary care, even psychiatry, or in an OBGYN practice or cardiology, and your go-tos are Lexapro, Celexa, Wellbutrin, look, these are in the red. Yeah. This is a tough report. This patient, as we'll get into this more, but they have a problem at 2C19 and 2B6 and the serotonin gene, and is pushing everything to the red that we typically go to first line. And so in that case, we probably don't want to go to this first line. And how else would we know that? So Dr. Anchera, what would you do in a patient with say, depression given this report?
Given this report, I would look at several things. Number one, I would look at the green and say, especially a patient who's naive to an SSRI, and say, what are the other clinical considerations that we need to consider? But we also need to consider what's based on formulary. And I'm looking on here and I'm like, oh, it would be nice to prescribe some of these, maybe the Trintellix or the Vibrid. But I also know that this is the first time they've been on SSRI. Maybe I can't do that. And maybe I do need to look at the yellow. Maybe I do need to look at, okay, let's look at Prozac. And I could look at, okay, it's in the yellow. Well, what are the clinical considerations? 1 and 4. And we know number 1 is serum level might be too high, lower doses might be required. Okay, all right, lower doses might be required. Well, we should always start low anyway. And then number 4, genotype might impact drug mechanism of action, result in moderately reduced efficacy. Okay, well, I know that too. Maybe then I'm going to start it and I'll look at maybe Effexor, where it's just says serum levels might be too high, lower doses might be required. And so it's looking at this and for instance, and then this is why I look at bupropion too. And I say, how many patients do I have that come in, they want to lose weight, but I know they struggle from anxiety and depression. And I want to really treat that depression because I know that's going to help them with their weight and their obesity, which is going to impact their cardiovascular system, which is going to impact their diabetes, which is going to impact their musculoskeletal system. And so just like I said, just because something's in red doesn't mean I'm going to shy away from it.
So many wise things that was just said in that conversation. Thank you. And I think there's a few things I want to specifically pull out and make sure that we harp on is that the categories are not prohibitive. You can prescribe across any category. When they were speaking of the clinical considerations here, they are always listed on the bottom of the report. You do not have to memorize them. You don't have to know them off the top of your head. You may begin to if you use GeneSight a lot, but it's always there for you as a guide. And so when they're talking about looking at these clinical considerations, they correspond to numbers on the report, which you will see at the bottom of each page. The other thing that I've heard, I feel like multiple times now, and I really want to reiterate, is that this is a tool that is meant to be used in conjunction with all other clinical factors you usually consider. This is not going to tell you how to prescribe or how to do your job. This is objective data that can be helpful in the process of medication selection. So thank you so much, both of you, for that information, because I feel like that is at the heart of making sure you use this report correctly, is knowing you can prescribe across category and making sure you have a firm understanding of these clinical considerations. Dr. Thomas, do you have anything to add for this here, how you use this, how you talk to patients about this?
Yeah, I wanted to say, Dr. Ranchero, thank you for what you said there about having another tool in your toolbox. As we all know, there's never enough tools we can have in the toolbox, right? And I feel like this is one of the best tools I've had to offer patients. I started in psych back in the 80s. And for me, it's one of the best things I've ever had, because it's not just one of the questions I always hated, and I would get it from young people, old people. It didn't matter the age, but in terms of how long they've been practiced or whether they were students, what's your go-to for this? My go-to is Zoloft, or my go-to is, people have go-tos. I don't like go-tos because oftentimes go-tos are disastrous. Sometimes they work, and that's great if they do. But one of the things that struck me when you were talking about that with the patient and with Dr. Felkel, with the example that he gave of his patient, Ethan, for a patient, time ticks a lot slower than it does for us. So for a patient who is really in depression and really struggling, to tell them, well, we're going to go ahead and start this and we'll do 4 to 6 weeks. And if that's not doing it, come back and maybe we'll increase it or maybe we'll switch. So those 4 weeks to that person is like, a day of our life goes by and they're counting minutes. I had a patient tell me one time, I got up and it was 10 o'clock and my rooster clock in the kitchen, and I counted how many hours before I could go back to bed. That's pretty telling when somebody is in the depths of despair to that degree. So I just think I always want to keep that in mind. Time just ticks a lot slower for somebody who's really struggling than it does for us in our busy day-to-day thing. It's not to say that maybe some of us haven't struggled with depression too. I'm sure we have. But I just think that it's one of the best things I've ever had to offer patients. And I like when people try to tell me it's not ready for prime time or there's not a reason to use it. We can try this first. I always use this. This works. Why would I do that? Why would I do that?
One question that we get a lot, and we've seen it in the chat, is how do you make time to do something like this? How do you have time, especially probably for you, Dr. Rencher, on primary care, or as you mentioned, you are, treating many, many comorbidities. So how did you make time for a tool like this in your practice?
Well, for me, it's getting the whole team involved. So my nurses and my medical assistants always do a PHQ-2, and then that goes to a full PHQ-9 if it's positive in the PHQ-2. And they already know that this is my clinical practice, and they can even proactively say, Dr. Ranchero will probably offer a test to you for a genetic testing to see which medications would be best for you. And it's also then saying at the end, after explaining to them what's involved, one of my team members is going to go into the room and let the patient swab themselves and put it in the container and watch them and give them the pamphlet. But it's making time, and maybe it's 30 seconds, maybe it's have a 30-second spiel of what GeneSight is and why it's so important and why it's such an important tool. But I think Dr. Thomas went right into it. So I'm not guessing. And so that I'm getting 6 weeks, 12 weeks ahead of where we need to be.
Yeah.
And then more importantly, one of the hats I wear as a consultant to large local employers in our region is we know that people who are depressed, how does that affect their quality of life? How does it affect their work? How does it affect their families? So we know if we can improve their quality of life, even 20, 30, 40, 50%, or in a specific area, and we could use this tool to help with that and really give that foundation that we need so that we don't have a year from now have 6 failures on medications and I'm sending them off to Dr. Felkel saying, here's a train wreck, sorry, go work with it. Good luck, Dr. Thomas.
Yeah, right.
Yeah.
Thank you. Dr. Felkel, I saw your hand up. Did you have a comment?
Yeah, just about, digging deeper into this report that you have up on the screen. In this case, I'm right there with you, Dr. Ranchero. I'm thinking maybe Effexor for this patient, because assuming the blood pressure is well controlled, because of that 4 next to the Prozac, because the patient's short of SLC6A4. But going back to my story about Ethan, like if there's any pain, fibromyalgia, I'm thinking Cymbalta. Duloxetine at low doses, it's more noradrenergic, so you don't get into that serotonin issue with this patient. However, there's this 7 by it, and I just wanted to highlight the inducibility of the 1A2 gene here. You'll see that Cymbalta has a 7, and Remeron, another great medicine, has a 7. There's a few other, but I don't know, Rachel, if you could just flip the screen once to the smoking page. So you have to ask your patients about if they're smoking, and then apply if they are, and smoking means not vaping or e-cigarettes, but the burning of plant-based products and daily. This is the report you would need to use. And I know, Dr. Ranchero, you kind of kept things at a high level. I have a tendency to go too deep on some of this, but what we're really talking about is a term called phenoconversion. And when you have these bins, the red, yellow, and green, we're assuming that is just that person's DNA and it's accurate. And it is. However, the things that we put in our body actually can change these bins, one of which is smoking. And so you can see now in the green, Cymbalta and mirtazapine are no longer in the green. They have a 2 by them. Kind of like that Wellbutrin dose, meaning that the dose may be too low, and maybe you need to ramp up to a higher dose, or maybe you avoid that Cymbalta or mirtazapine altogether. I wanted to bring this up because for the people that are treating with antipsychotics, if you'll go just a few more pages, Rachel, to the antipsychotic page, look at how many medicines have a 7 by them. They're some of our best medicines: clozapine, olanzapine, Haldol. So if your patient is smoking, and Rachel, you go one more page, you'll see that these are now in the 2. Somehow haloperidol is still in the yellow. But olanzapine, if you have a manic patient and you're going to do lithium and olanzapine, I bet that olanzapine blood level may not get up to where you need to be unless you treat them with the right dose of the medicine. So just smoking really impacts the patient. And also, I think there's more to come on this, but eating edible gummies, cannabinoids, THC, that also may phenoconvert 3A4 to poor inhibitor status. So we really should be asking about what people are putting in their bodies. Not to complicate things too much, but if someone is taking, say, Prozac, it makes them a poor 2D6 metabolizer, and all of this information will change. So we really need to be taking a good history about phenoconversion.
That's a great point, and I was going to talk about that too. Like, we don't commonly think to ask, or a lot of people don't commonly ask patients about CBD. You can go to the gas station, fill up, get some bread and milk and a bottle of CBD on the little thing as you're checking out, and they don't think that's anything because they just got it right there where they were getting gas. And CBD is an inhibitor of 2D6. The same with diphenhydramine. And you talk to patients and they don't always tell us what over-the-counter meds they're doing. And you might say, well, you've been having trouble with sleep. Are you doing anything? Well, I'm just getting that stuff at Kroger, NyQuil or Tarquil or Walquil or whatever the quill is. And the active ingredient is diphenhydramine, potent 2D6 inhibitor. So that's exactly what you're speaking to, Carson. I know one of the things that struck me when the 1A2, when we started putting that on the report in August, I think it was, I started thinking about the SPMI population, and when patients are in the hospital and they're schizophrenic or bipolar, whatever it is, and they're in there. And back when I worked inpatient, patients got smoke breaks, and I was curious, are they still giving smoke breaks to patients in the hospitals? And I did a little poll among a bunch of colleagues online and found that some places do, some don't. Some try to replace the cigarette nicotine with lozenges. They think that's the issue, but they don't do anything about the THC. So patients will get stable on this amount of this medication, then they'll leave, they'll go home and go back to their usual habits of smoking a pack of cigarettes a day, a couple of blunts a day, and suddenly they're back in the hospital. And so we look at increased rates of recidivism and, just the clinical burden and the financial burden. They're starting to be more recognized, I think, among not just us, but I think among researchers and among the communities at large who are becoming informed about this. But I think it's going to take all of the people that are here tonight really coming together to look at how does this impact our patients on an individual basis, but also on a societal basis. Because when you think about that with the SPMI population, that just really struck me when I started to think about that. How many of those patients do well in the hospital, they go home and they're back, in a month, and people can't, are you not taking your medicine? No, I'm taking it. And then people are thinking, oh, they're probably not taking it. They're non-adherent. Maybe they're non-adherent, but maybe they're just smoking again as much as they were before they came into the hospital. So thank you for saying that. I had to throw that in because that's something I feel really strongly about too.
Thank you all so much. So I do want to provide a little bit of context for the smoking update that was talked about. Recently, there was an update to the GeneSight report that takes into account a patient's smoking status. It's based on one gene that we look at called CYP1A2, which can be affected by a patient's smoking activity. So that is why you will see smoking and non-smoking pages for the interpretive portion of the report now. So just wanted to make that clear here. And I think it's a really nice segue into the next section of the report. So these first pages here, the green, yellow, red, this is where most of the information is. This is where most providers choose to stay because it shows you the binning, it shows you the clinical considerations, and this is what helps assist with the medication selection process. But if you are interested, if you go past these green, yellow, red pages here, you will see that there is a section called patient genotypes and phenotypes. We look at two different flavors of genes on the GeneSight report. Pharmacodynamic genes, which the names are listed here. The results for each patient is listed on the right with a little blurb about each. And we also look at pharmacokinetic genes, which are metabolism genes here, which again, the name is on the left, the result is on the right, and a little blurb about each is found below. So this is an area of the report that is considered supplemental information, but we wanted to dive deep in the report tonight to share all of the information you can use on the GeneSight report. So I'm going to turn it over to Dr. Thomas. I would love if you wouldn't mind to tell us more about the pharmacokinetic and pharmacodynamic genes that are found in this section and some clinical implications and how they affect your prescribing.
I think that I like to look at the clinical considerations as a really juicy part of the report. I love the clinical considerations part, but I think this part is also a really important part. When you think about what those pharmacodynamic genes, pharmacokinetic genes are, that all has to do with metabolism of medications. So when we're looking at those pharmacodynamic genes, that affects where drugs hit the drug receptor binding site. And we're looking at response and risk, basically, or risk of side effects. And when we're looking at the pharmacokinetic genes, I always think that's what the body's doing to the med, the pharmacodynamics, what the med's doing in the body, to be reductionistic in saying that. But those pharmacokinetic genes, we're looking at, ADME, ADME, we're looking at absorption, distribution, metabolism, elimination, all those factors, which are really important to, are we having an efficacious blood level or are we in the toilet with it? What can help to explain that? So when I'm explaining to newer providers, just simply, I look at genotype as kind of the ingredients or the recipe ingredients for the cake, and the phenotype is the cake, what shows up. So it's how it interacts with the environment, as I think Dr. Felkel said. It's not just the gene, it's the gene and other environmental factors, other things that we put into our body, all those kind of things play a role in what shows up beyond the report. But a lot of times people will come into our office and say, I'd like to try this medicine because it worked for my sister. So sometimes I'll explain to them and to my colleagues that just because a family member has this set of genes and this med worked for them, that doesn't mean because you're her sister that you're gonna have the same response to medication. And we know that, but a lot of people don't know that. And I think that's just, it seems like a little unimportant thing, but I think it's really important to share with people. I think it was interesting, Carson, when you were talking about your patient, very similar to a case study that I used, like one of my first 3 patients I did GeneSight on. Slice 6A4 was 2 short alleles, had increased sensitivity, poor 2D6 metabolizer. I think it was a 2, I forget what the other one was, but everything just spoke to why this particular patient had failed so many meds in the past. And he had been on nortriptyline, all the basic SSRIs. When he came into my office, he was on 10 milligrams of Lexapro. And he sat there and he was really pretty fed up with different medicines from people. And he had started off with his primary care way before GeneSight ever came along. This was back in the 90s. And what I'm talking about happened in 2012. And he sat there and he said, every time I take it, my stomach is just horrible. And I could hear it kind of gurgling. And I have to own this. I thought to myself, oh my God, you're only on this amount of this. My 96-year-old mom takes that amount of that, and she's fine with it, Well, how wrong was I when I got his GeneSight report back and I needed to give him a big old apology? It's patients that I still see on occasion as needed. But everything was in his red column except for 2 meds. It was MSAM. I still remember MSAM and Prestige was the only thing in his green column. We did an update on him in 2017, I think, and his MTHFR was also in the red. So everything showed him why he had failed so many meds. On a practical level, taking all of the science and making it practical for a patient, it helps them not to feel so defective. Like, why is it nothing? We've all had the patients that come in, nothing works for me. I'm really sensitive to meds. My mom was too. Okay, what does that mean on a practical level? It means that we just need to do a better job of deciding what meds to use. And I think, Dr. Rachel, you kind of intimated this when you were doing your section about it's a collaborative approach with our patients. It doesn't make us be up here and here's the patient ever so benevolent to do what we say. It helps them to understand the reasons that we're doing this. And when I can work through it, most of my patients are professionals, so they can, sometimes they want all the information. I've had other patients who are quite intelligent, smarter than me, can definitely, figure it out or follow along. And they've just said, just tell me what to do. Maybe later they want me to go into it more, but I tell them, unless you get a liver transplant, this is your DNA. It's not going to change. We're going to find out more things. We're going to continue to evolve, hopefully, as a science. We're going to understand more about what we already know and learn a lot more. So I think looking at this section, the pharmacodynamics and pharmacokinetic genes, I think that's just really important to understand. What is it about this that makes this med not work for you? The easy one is the Slice6A4. That's the most studied gene in psychiatry, is that serotonin transporter gene. Then we go over to the pharmacokinetic genes, and 2D6, that's the most polymorphic of the genes. It's a lot of, I don't even remember the number of variants that there are, but I think interestingly, there's a number, I think it's like 20 to 25% of FDA meds, approved FDA meds, are partially metabolized by 2D6. I want to throw in there that a lot of meds are metabolized through multiple pathways. It's not just only 2D6 or only 3A4. There's often multiple pathways. And the thing about GeneSight that I really appreciate and like a lot is the combinatorial approach. It's not single gene testing. It's the combinatorial approach, and that algorithm that's used. I don't have to explain that to somebody. I'm not a bioscience tech person, but I can understand it enough to share with a patient why this makes sense. When you look at maybe 3A4 metabolizes a little bit, so it gets a little slot. Maybe it's mainly metabolized by 2C19, so it gets a bigger ball in the court. So I like that those are weighted when it's fed through, and when we come out with what gives us the phenotype for our patients, how we can help better understand that information and help our patients to understand why we're suggesting the meds that we are, because now we have support for that. Obviously, clinical judgment always has executive veto power. We take all the things into account, but now we can make sense of it and explain it in a way that is logical to them.
Thank you.
Yeah, it's 25%. That keeps bugging in my head. Oh, I know what I was going to say about that. So thinking about 25% of FDA approved meds, the reason that number is so important is because 2D6 is only about 2 to 4% of the hepatic enzymes, period. But yet it gets this big old slice of pie of medications that it's part are very important in the metabolism of those meds. So I get all excited talking about it and lose what I'm even saying, because I want everybody to just use this. That's my truth. I want everybody to appreciate the benefit of this for our patients.
Yes. And I think one of the big takeaways I'm hearing, and please other panelists chime in as well, but this information that you're getting in this section of the report is the why. This is why the medications are placed in the certain bins with certain clinical considerations. And you can review this information if you'd like with your patient. It explains what genetic variability is present in your patients for the genes we test for. I would also like to point out briefly, and then I'll turn it back to the panelist on this section. If you don't want to go over this section of the report with your patient, you're not comfortable, you don't have the time, there is a medical team that is available, a team of MDs, PharmDs, and PhDs that are available upon request via email, via phone, to schedule a consultation. They will walk through it with you. There are also genetic counselors for patients. So you do not have to feel comfortable walking through this. If you do, that's fantastic. But this is kind of feeds what the why behind the report. Dr. Felkel, did you have a comment?
Yeah, I have a lot, but maybe we'll have another webinar to go even further into this. But just on this page, an interesting finding here is that HLA 3101 is positive, putting the patient higher risk. That's why carbamazepine Tegretol is in the red on this patient. But if I'm thinking about a mood stabilizer and anti-epileptic medicine, certainly I'm not going to use Tegretol. But you can see that Lamictal and Trileptal are probably safe because the HLA-B1502 complex is normal. And then if you go to the pharmacokinetic page, since the title of this presentation is Going Beyond, I just wanted to call out the UGT enzymes at the bottom. I think these are fascinating. You never learn about phase 2 metabolism, maybe like for a minute in med school or something, but there's this whole other metabolism pathway called glucuronidation, phase 2 conjugation. And UGT1A4 does olanzapine and lamictal, and it's usually a gain of function mutation, meaning your lamictal levels or your olanzapine levels could be too low. So olanzapine can be hit because of smoking, but also because of UGT1A4, also touches Depakote. And then lastly, for primary care, maybe this is in your world, Dr. Anchero, so many patients on benzodiazepines. We sometimes say that lorazepam, oxazepam, temazepam doesn't get metabolized through the liver. That's just not true. It gets glucuronidated through this UGT2B15. So you'll see that affecting the benzodiazepines. And maybe you say, hey, I don't prescribe oxazepam or temazepam, but if you have a patient on Valium, diazepam, it becomes oxazepam and temazepam going through this pathway, which frequently is impaired, probably raising that Valium or lorazepam dose, and you don't even know it.
Yeah, that's a good point.
Thank you. We got a question from a participant that is relevant to this page, so I was going to answer it here. The question is, why is e-cigarettes included in smoking? I thought this was related to nicotine. So the reason I brought it up, this question, is because this is related to the CYP1A2 gene right here. And if you look at the definition of smoking, it's the actual burning of plant material. So when you burn plant material, it produces polycyclic hydrocarbons, aromatic hydrocarbons, and that is what activates the gene. So it's not actually the nicotine or the marijuana itself, it's the burning of plant material is what induces that gene if you carry the inducible version of that gene. So good question there. I want to make sure we have time to go to the last section of the report here, which is called the gene-drug interaction chart. At a high level, this chart is organized the same way the beginning is. So there's a green section, a yellow section, and a red section. And it lists all of the genes that the metabolism genes we test for on the report. And it tells you which genes are involved in metabolism of each medication on a report. We've heard this called the secret sauce, and we've heard that this can be very useful when people realize that it's there. So Dr. Felkel, I want to turn it over to you to ask how you use or if you use this information when using GeneSight.
Yeah, I certainly use it every time. It's probably the least looked at page, but after you've maybe done 50, 100 GeneSights and read the entire report every single time, you'll start to say, I think I can see a pattern. I know that med goes through 2D6, but does it also go through 2C19 and 3A4? And so this is your cheat sheet. You can also always look at a number of websites. CPIC is a great pharmacogenomic consortium that has all the clinical pathways. And so there's a lot of tools out there, but this is your quick tool because it also reminds you at the top horizontally what pathway is impaired. Let me tell you a brief story and then kind of go back to this. So when I was under the care of Dr. Anchero, him being my preceptor, me being a med student in family medicine, I often had to turn to my Harrison's Internal Medicine book. And I'm sure many people on this call have one. At the time, I did not know that Dr. Anthony Fauci authored it. And now we all know his name. It's a common name in every house. And if you go to chapter 7, and I would encourage you to pull it out after this webinar, you're going to see it say from 2010, my copy, I'm sure yours is either earlier or later, but you'll see in one of the chapters on pharmacogenomics, if you're going to prescribe a beta blocker, you need to know 2D6 status. And so that was like years ago, it was written in that book. And the reason for that, you can kind of look down here under the anxiolytic section, you can see propranolol or Inderal. So you can see here that Inderall goes through 1A2, and so we have to apply smoking status there, and 2D6. And like it's been said, 1 in 5 patients have a problem at 2D6. You could be an ultra rapid metabolizer or a poor metabolizer, but there's a problem there, and it does most of our meds. So Dr. Fauci in Harrison's internal medicine book is saying we got to know 2D6 status on beta blockers, because if you're a poor metabolizer, you can have more bronchospasm or bradycardia. Now, let's layer that into the psychiatric world. Now, if you're Dr. Ranchero, you're probably using that for blood pressure. In my world, I'm using it for PTSD, or a golfer whose hands are shaking while they're putting, for performance anxiety. But let's say they have PTSD, still have a lot of hypervigilance, kind of that cortisol rush, and I'm going to add on a beta blocker, propranolol, to my Prozac. Well, I need to remember what pathways does my Prozac go through? So I think, Rachel, it's on the yellow section here. There it is. Fluoxetine, go back a page. Yep. You can see here, fluoxetine Prozac, second in the yellow column, goes through 2C19 where there's a problem, 2C9, 2D6, and 3A4. Circles mean it goes through that pathway. A filled in circle means there's a variant allele there. So now imagine that my Prozac, which I know is going through 2D6, it's also a 2D6 inhibitor, so it's inhibiting itself. And now let's say the patient's a poor 2D6 metabolizer. I'm not going to use propranolol. So high level, these dotted pages, the more you look at them, this is our best estimate of how to reduce polypharmacy and or create rational polypharmacy, avoiding medicines going through the same pathways, especially when they're impaired. Lastly, if you'll just go a few more to the red section, we'll see the meds that are in reds. Just again, highlight if you're in primary care, look at how many SSRIs or NDRIs, so Wellbutrin, Celexa, Lexapro, Paxil, Zoloft, they are really impaired in this very common report. And so I probably would avoid those first line.
Doesn't it make you wonder if maybe that's the reason about 35% of first med failures are because of the go-to is the SSRIs?
It definitely makes you think. Absolutely. There's another question that came in through the chat that's was shown on this page here, but it can also be found in another section of the report. So anyone is welcome to answer this. Can you please speak to medications in gray categories? We've been talking about green, yellow, red. Does anyone feel comfortable answering that question?
I'm happy to speak of it just because we're staring at amphetamine salts right here with no proven genetic marker. A number of medicines, they get renally cleared, or we don't know how they're metabolized, or they go a pathway that just has no genetic variation that we can act upon. For instance, lithium, everyone knows it's renally cleared. We can't look at the cytochrome P450 system to approach that medicine. What we're looking at right here, just to take an easy one, amphetamine salts. This is a little more controversial here. According to GeneSight, it's not going through any pathway. If you look in Hippocrates, it's still going through 2D6. All the amphetamine salts are. So as the clinician, I'm kind of hedging my bet. If there's a problem at 2D6, I'm probably going to go lower on an amphetamine or maybe stick to the methylphenidate product. But there is another gene that affects methylphenidate products. It's the CES1A1 gene. So you got to know that too. But here we have mood stabilizers up, Neurontin renally cleared, lithium renally cleared. Topamax, I think, may slightly go through 3A4, but it's not impacted enough to make a clinical decision off of it. I don't know, Rachel, what would you add? You're the pharmacologist.
No, you nailed it. Essentially, if you see in gray, it doesn't mean don't prescribe. It just means that with the current body of evidence that we have now and the genes we test for, we can't provide guidance on them. So you answered that beautifully. So we've gone through the 3 different sections of the report. We have the interpretive portion here, which is the green, yellow, red with clinical considerations, where you will find the most clinically actionable information. We've gone over the genes that we test for and your patient's results, and then the gene-drug interaction chart. There are 3 sections of the report that you can utilize, and we wanted to talk about those because they are considered a deeper dive topic. I've gotten some questions in the chat, though, that I would love to get some answers from the panelists. So this can go to anyone. I'll start with Dr. Ranchero in a second since we've heard from you. How did you choose a pharmacogenomic test? What was your decision process look like when you were picking a test to use?
One of the biggest things is the longevity of the company, the service of the company, who the representatives are, who can service their accounts. That's a big thing. And also, if you look at it, you have to have the data behind it. And so having people like Dr. Earls who have the data behind it and can explain it to the patient. And if I want, like you said, if the patient has deeper questions, I can say, hey, there's an 855 number at the top right corner there. And there are geneticists, there are people who can talk to you about this if you have deeper questions about this. I don't know if the other thing that I like about this GeneSight is it does test the MTHFR gene as well. I don't know if you're going to go into that, but that's a big one for a lot of my patients when I say, hey, you're not even making enough neurotransmitters. And I appreciate that GeneSight tests that as well.
I agree with that. And my answer to that question right off the top of my head, Rachel, is it's the combinatorial approach. If all other things being equal, that one thing alone would make me choose GeneSight as opposed to any of the others, because I want to know that information, not just a single gene. You know, I can look at 15 single genes, but I want to know all of those together and how they're weighted out to look at those variants, because that's what informs those clinical considerations in the first part of the report. So I think that's just really, really, really important. And I agree with you, Dr. Ranchero. It just makes sense. And it's not going to change. That report's not going to change for our patients. We can update it. It's not more costly. I had a patient a couple of years ago that said, is it time, do I need to get that rechecked again? And I said, you know, she thought it was like drawing labs, like she had to get it done every couple of months. And it's like, no, this is yours. This is your DNA. So, you know, I thought that was really good. So to me, that's just the combinatorial approach, all things being equal, that just wins above everything. And I agree with you 100% on that MTHFR. When you look at that carbon 1 metabolism, grabbing a little homocysteine, it's the basis for all the neurotransmitters. It's another one of those things. I've got a patient right now who said, you know, I can't get over, you fixed me with a vitamin. She'd been on lots of medications her whole life, and she came to see me. I'd put her on, this was before I started doing GeneSight, I put her on Lexapro, and she took that for like a year or two because her sister took it and she wanted to take that. And then I started doing GeneSight, and I did GeneSight on her. And Lexapro was fine for her. It was in her green column, but MTHFR was in the red. We corrected that, got her off the Lexapro, and it's been years now. And she still jokes about that. I see her daughter now, and she's like, tell her to check that thing that gives you the vitamin.
Thank you. We just received a great question, again, open to the whole group here, but I do have concerns that this is not ready for prime time, and the impact is pretty profound if we get medications wrong, because we might not be giving med options that could have worked. How do you talk to patients and colleagues around how reliable this testing is and what the potential risks are?
I'll just start by, I've already mentioned CPIC, but I would encourage this individual to go to CPIC's website. It's cpicpgx.org. It's non-lab pharma bias. It's a consortium of clinical pharmacologists, and really talking about the utility of the test. And from there, you can see that this consortium makes recommendations to the FDA, and then the FDA puts these dosing guides into their package inserts. And there's a new update on depression, which you should read. It's fascinating, but they're really keyed in on 2C19 and 2B6 and 2D6. And so, for instance, they say if you're a poor 2D6 metabolizer and a poor 2B6 metabolizer, you should start a quarter of the initial dose of Zoloft. That's something people aren't really talking about. But this is in so many of the meds we're prescribing. Strattera, atomoxetine only goes through 2D6. And so the dose is way too high if you're a poor 2D6 metabolizer. So the FDA is already putting this information in. If you choose not to read it or to pay attention to it, I'd say that that's a bad idea. We are held accountable for the information that's already out there. And this is already out there. We just have to learn more about it, which can be really scary. I really appreciate GeneSight's white papers. That's where I learned a lot of this information. They'll say, these 3 studies refute it, these 7 are in favor of it, so this is why we're using it. It's definitely a gray area, but we're using the best information out there. Not to mention, Dr. Ochero already said, doing a big 1,200 patient study, can a psychiatrist do better using GeneSight when they move a patient from red to yellow or green versus a psychiatrist not using GeneSight, and they won. They did better. So in terms of remission.
Thank you.
You know, one thing I want to share is that when I talk to the patients about the overall view of this, and I say, look, you're on life's journey, and we want to get you to a better place. Whether it's dealing with the anxiety, dealing with the depression, dealing with the mood disorders. And just like when you take a road trip, if you're going to go out west, I can say, hey, get on this highway and maybe hopefully you'll get there. But what if you had a roadmap? What if I could say, hey, you know what? This highway, is a better way to get there, or this venue, this way, this pathway is a better way to get there. Which would you rather have? Would you like to wander for a little bit, or possibly guess, or make a more educated decision? And again, this is simply a tool, and it gets us to that, hopefully, to that place of remission, or that place of quality of life that we want to get to in a faster way.
Thank you. We have 1 more minute. Last question. I've gotten this quite a few times tonight. Who are you using GeneSight testing on?
Everybody. I'm a big believer in preemptive rather than reactive testing, but that's just my personal approach.
I'm with you, Dr. Thomas. Preemptive testing. I'm with you. Primary care.
I think every patient should know that it's a tool out there, but if you want to be evidence-based, I would say a patient needs to have failed 1 medicine. However, a lot of patients also don't know their MTHFR status and maybe don't need any medicines at all.
Wonderful. Well, I cannot thank our panelists enough for their wisdom and their time tonight. Thank you for your thoughtful questions from the audience. We are working to answer them as quickly as possible. We appreciate your engagement. Please go to genesight.com website to learn more. We have plenty of resources on the website. As Dr. Felkel mentioned, we have white papers, we have summaries of our clinical evidence, we have links to resources there. So please do not be a stranger. And I just want to sincerely thank everyone for their time. And I hope you learned something new about the GeneSight report tonight. And we will try to follow up as quickly as we can with questions.
Can I say one more thing?
Yes.
I think GeneSight is like an interaction checker instead of having to use the old PDR. Like we used to put our fingers on one med and flip to another one, put our finger there and flip to another one, put our finger there. GeneSight's like having an interaction checker, like on Hippocrates. So that's all.
Thank you. I hope everyone has a wonderful night tonight. And thank you again for your time. We appreciate it.
Thank you.
Bye. Thank you.
Bye.